Alrighty, we'll go ahead and kick things off. Good evening, everyone, and thank you for joining our men's health webinar. We're so excited to have the opportunity to share important men's health education with this group today. My name is Lee, and I am the host for tonight's event. I'll start with a couple of quick housekeeping items, and then I'll introduce our speaker. Most importantly, your participation is completely anonymous to other attendees. No one can see your face or your name, and any questions that you ask will only be seen by myself and the speaker. We encourage an interactive presentation, so if you'd like to ask a question, please type it in the chat box at the lower part of your screen, and we'll save time at the end to answer as many as we can. Tonight's webinar will be presented by Dr. Brittani Barrett-Harlow, a urologist and men's health specialist with Georgia Urology. Dr. Barrett-Harlow, I know your time is in high demand, and I appreciate your willingness to be with us this evening. I'll go ahead and turn it over to you.
Hi, thank you guys for tuning in tonight. I am always glad when we're able to do webinars because patients can tune in from the comfort of their home. And sometimes that allows you to feel more comfortable to ask questions that maybe you wouldn't ask if we were in a group setting. So as Lee stated, if you have any questions throughout the presentation, please feel free to type it in the chat box. And then towards the end, we'll have a little bit of time for Q&A. So tonight we're talking about men's health, specifically erectile dysfunction and stress urinary incontinence. And just a little bit about myself. So I'm a native of Atlanta. I went to college at Emory and medical school at Medical College of Georgia, and then went out to Houston for a couple of years to do my residency, but then spent extra time really focusing on prosthetic urology. So I truly specialize in men's prosthetic urology when it comes to different devices for erectile dysfunction, as well as urinary incontinence. And I also treat difficulties with testosterone and Peyronie's disease or curvature of the penis. So let's start off talking about erectile dysfunction. A lot of times guys will come in and they say, I can't get an erection at all. And I say, okay, yes, that's ED. But sometimes patients come in and say, no, I can still get an erection, but it's just not the same. It's not as hard as it used to be. It's not lasting as long as it used to. It's more challenging or takes more effort for me to get an erection. And that still falls underneath ED. So I always say erectile dysfunction is not a zero-sum game. It's not that you can't get anything at all or that you get a very good one. It's just a change to the quality or characteristics of your erections. And what we know is that it's quite common. So 40% of men over the age of 40, or I'm sorry, 50% of men over the age of 40 have some form of ED, okay? Whether it's just a little bit more challenging to get one or not getting one at all. And we know that 1 in 5 men over the age of 20 start to have difficulties with erections. And sometimes that may be a psychological component. So if you're more stressed, got a new job, have extra stressors on you, that can contribute to difficulties with erection. But as we'll see, other medical problems also contribute. So when you think about what an erection is, it is just blood flow, okay? And the penis basically has 2 states. It's either soft, what we call flaccid, or hard, what we call erect. When you get an erection, what happens is the nerves in the penis allow for the blood vessels there to dilate. And so you get blood that rushes into the penis. And as that blood rushes in, the veins that are there also kind of squeeze shut, and that keeps the blood there. So I liken it to a tire on your car. You've got to have air in the tire, and you can't have any slow leaks. If you're not getting air into your tire, blood is not rushing in, whether it's due to a vessel issue or due to nerve damage. If you're not getting air or blood into your tire, the penis is not going to get erect. And if those veins are leaky for whatever reason, that air is going to rush out. And so it's not going to stay as rigid. And so if you're having issues with any of those things, you'll have difficulties with your erections. When we think about the most common causes of ED, you'll see the top 3 causes there: vascular, meaning high blood pressure, cardiovascular disease, something wrong with your blood vessels, right? Diabetes. Diabetes tends to affect the nerves and the blood vessels. And so that makes it more challenging to get your erection and to keep it. But then other things we know contribute to it. So age, smoking, if you've had any pelvic surgery, pelvic trauma, pelvic radiation, all of those things can affect the blood vessels, the nerves, and cause issues with erections. And the thing is, although it's a medical thing, right? Although this is a medical diagnosis, it definitely affects you psychologically. And we know that patients with ED are at a higher risk of developing anxiety. Am I going to be able to perform tonight? Are the pills going to work? Am I going to stay hard long enough to satisfy? It can lead to depression, decreased self-esteem, and then decreased quality of life. And so I always tell my patients, if this head's not in the game, the other head's not going to be in the game. And it kind of becomes this cycle of not being sure, becoming anxious, becoming, more self-aware, and perhaps having lower self-esteem. And then it just keeps going. And so we want to talk about treatment options to kind of get you out of that cycle. When we think about ED and diabetes, we know that patients who are diabetic are less likely to be as responsive to pills. So think Viagra, Cialis, Levitra, Stendra. Sometimes patients will say sildenafil or tadalafil, some of the generic components, but they're less likely to be responsive to it. And the reason being is how that diabetes affects not only the blood vessels, but the nerves. So over time, when you have diabetes, and perhaps your A1C is under control now, right? You're less than 7, but that time where it wasn't, the blood vessels and the nerves to your erections, they get compromised. And some of those things we can't undo. And so we know patients with diabetics are at a higher risk of having ED, but also having ED that's refractory or doesn't respond to tablets. Other things that we know increase in men who have ED and have diabetes. You tend to be older. And as we age, just like with everything else in our body, things change. We talked about vascular disease and how the blood vessels can change due to diabetes. And certain medications that you use for high blood pressure or for diabetes can also affect your erections. When we think about heart disease, remember I said an erection is just blood flow. And the purpose of your heart is to pump blood to all the parts of your body. So if you're having issues with the major pump, right, your heart, and blood pressure issues, you're absolutely going to have issues with your erections. So we know patients who have any type of heart disease are within 2 to 3 years, they're likely have some type of symptoms with ED, and vice versa. So sometimes I'll get a guy who's, say, 35, healthy, no other medical problems, and he says, yeah, I'm starting to notice problems with my erections. One thing that I'll tell him is, hey, you definitely want to plug in with a primary care and see them routinely, because we know that he's at a higher chance of developing some type of vascular issues within the ensuing years. And I really like this diagram because it kind of gives you an idea of what these blood vessels look like. So if we look at the femoral artery, this is a large blood vessel in your groin. It kind of supplies the entire leg, right? And you have one on each side. So think about how wide that looks. If we look at the internal carotid, so right next to it coming down, that's one in your neck. And it gives major blood flow to the brain to help you think well. If there's any issues with blood flow there, sometimes patients will have a stroke. And then next you think about the artery to the heart, the main artery supplying the heart so that the heart can work. And then you look at the penile artery. It's the smallest of all of these. So if you're having blood pressure issues where we're picking up blood pressure problems in your neck, or you're having vascular issues to your legs where your legs are going numb because there's something wrong with the blood vessels there, or problems with your heart because there's blockage or plaque buildup in the blood vessels there, think about the plaque that would be built up in the penile vessels. And they're much smaller, and so they become occluded or blocked faster. And so you're not getting air rushing into your tire. So it's difficult to get an erection. So what can you do to help prevent that, right? Heart healthy diet, exercise, great things. Going to definitely increase blood flow. They may not completely correct your ED, but they can prevent it from getting worse. And that's a big component, because we know when patients have difficulties with erections over time, when they're not getting good nighttime erections, they're not having good routine rigid erections, they start to lose length. And the reason being, when you're not getting good blood flow routinely to the penis, just like if you aren't working out your muscles at the gym, that muscle starts to atrophy or it starts to shrink. And the more you work it out, the bigger it stays, right? So if you're not getting routine blood flow, we know that the penile tissues can atrophy. They can kind of shrink down. And the challenging part is we can't recapture that. So you want to do everything you can to preserve the length that you have today, preserve the function that you have today, and heart healthy diet, not smoking, watching or limiting your alcohol, all of those things contribute. The other thing that we know contributes to erectile dysfunction is low testosterone. So after about the age of 30, testosterone starts to change in men. And testosterone really is like the fuel for you. So it helps with your energy, with your sex drive, with your metabolism, also helps with your erections. And so we know that for men who have low testosterone, if we can correct that, they're more likely to respond better to pills like Viagra, Cialis, Levitra. And so there is a correlation between the two. And like I said, some of the symptoms of a low testosterone can be decreased sex drive, decreased energy. You may notice that the testicles seem smaller in nature, more fatty tissue instead of muscle. And there's treatment options for testosterone, multiple different ones, from pills to injections you give yourself, injections we give you, little tablets or pellets that we place underneath the skin, multiple treatment options, but you definitely want to be seen to be treated and evaluated. And then ED related to prostate cancer. So I know we're talking a lot about erectile dysfunction as well as stress incontinence tonight, but I'd be remiss if I don't talk about prostate cancer and prostate cancer screening. Prostate cancer is a silent disease. It does not cause you any symptoms. Once it's causing symptoms, it's typically too far gone. It's no longer localized to the prostate. So if you're not being screened for it with blood tests, with rectal exams, we'll miss it until it may be too far gone, okay? And it's the second most common cancer in men, only second to skin cancer. And it tends to be come on earlier and be more aggressive in African-American men. So make sure, I know we're talking about ED and urinary incontinence, but make sure you're being screened for prostate cancer every year, PSA, rectal exam, okay? When we think about prostate cancer and some of the treatment options that we have, those treatment options can affect the nerves and the blood vessels, and thereby they can affect your erections. So think about when we do prostate cancer surgery and we remove the prostate. The prostate, as you can see on the left side of the screen, it's a gland that sits at the base of the bladder, and the urethra, the urine channel, goes through the center of it. If my fist, hopefully you guys can see this, but if my fist is your prostate, the nerves that allow you to get an erection, they run right alongside the prostate. So when we do surgery to remove it, we kind of peel back those nerves and just remove the prostate. And then we reconnect the urethra or your urine channel to your bladder. But although we may do a nerve sparing technique, right, where we peel away those nerves to leave them behind, those nerves still become inflamed, they become irritated. And so we know after prostatectomy, after prostate cancer surgery, there can be a change to the quality of your erections, where prior to surgery, you maybe didn't require Viagra or a Cialis or injections, but after surgery, you might have to. So don't let that be a thing to stop you from getting your prostate cancer treated. But we know after prostate cancer treatment, you're more likely to have issues with the erections. And there's still things that we can do to get you intimate and get you functioning. And then ED and Peyronie's disease. So Peyronie's disease is scar tissue in the penis, okay? If we think about the penis again, think about it now like a balloon, right? When you get an erection, the penis gets wide, it gets long, it stretches out every single nook and cranny. When there's scar tissue in the penis, whether it's due to an injury during sex, whether it's due to kind of small injuries over time, that scar tissue is like concrete. It does not stretch. So it acts like a fulcrum. So when the rest of the penis is getting wide and getting long, that fulcrum causes the penis to bend in any direction, back at yourself, down to the ground, left, right, whatever the case is. And typically for patients who didn't have a major injury to the penis, the reason why they develop Peyronie's or scar tissue in the penis is because over their years of penetrating, if the penis wasn't as firm as it should be, you're more likely to buckle, right? So as you're inserting, the penis bends a little bit, maybe doesn't hurt you, doesn't hurt your partner, you keep going. But each of those small bends create a small tear deep down in the tissue. And those tears, just like if you cut your hand, eventually they heal as a scar. And that scar is what causes the curvature. So we know there's a correlation between ED and curve or Peyronie's disease. For Peyronie's disease, there's treatment options. Typically, oral medications are only really helping with the discomfort because sometimes having that scar tissue can be very painful. But there are surgeries that we can do specifically for the scar tissue. There are injections that we can give into the scar tissue. And then there's also surgery with a penile implant that we can use. So if we think about treatment options for erectile dysfunction, right? The first thing I'm going to say is make sure you go to someone who actually treats this. There are a lot of television ads or radio ads of come here, we're definitely going to get you fixed, or you get your money back guaranteed. Be careful where you go, right? I am not a mechanic. If there's something wrong with my car, I'm taking it to a mechanic. If there's something wrong with your penis, take it to a urologist. Take it to someone who has studied and trained to treat it, not someone who maybe took a 3-day course and now is telling you they can treat it. Okay, so just make sure you find someone who actually specializes in it. In general, there's 4 different treatment options, and we're going to kind of go through all 4, but there's tablets, vacuum devices, injections, and surgery. Always, if you're a patient of mine, you know that I say this every time. I always talk to you about behavioral things, medicines, and procedures. So behavioral wise, kind of what we've been discussing. If you have diabetes, keep that under control. If you have vascular issues, heart healthy diet, exercise, help that blood flow. And if there's a psychological component where it's I'm having issues getting over a mental blockage, there's sex therapists, and it's nothing to be ashamed of, right? I tell patients sex is expected. It's how we procreate. It is an erection is just a medical diagnosis, right? If you're having ED, it's a medical diagnosis. So get medical treatment if you need it. Okay, so when we think about tablets, that's Viagra, Cialis, Levitra, Stendra. They all work the same in that they do not let you get an erection on your own. They just increase the likelihood for you to get and keep one. So you still need foreplay, you still need stimulation, you still need date night, okay? You typically want to take these medicines at least an hour before any planned activity so that it builds up in the system. I always tell you that doesn't mean minute 61, you're like, honey, let's go. I only got 30 minutes, right? It just means that it takes an hour to be available, okay? You want to be careful if you have any issues with angina or chest pain and you're using like nitrites or pills that you place underneath the tongue. We don't like to use those medicines with Viagra or Cialis because it can really lower your blood pressure to a dangerously low level. So we typically don't use these medications in those patients. Side effects can be sinus-like headache, sinus congestion, lower back pain or muscle pain, as well as reflux-like symptoms. And like we said before, we know men with diabetes are less likely to be responsive to tablets. A vacuum erection device, so that's a device that you place over the penis. It creates a suction to pull blood into the penis so that it gets firm. And then use a constriction band, for lack of a better term, a cock ring, and that traps the blood flow there. So remember, we talked about that tire, right? We want to trap the blood flow. We don't want any slow leaks. So that constriction band helps to trap the blood flow there. And the vacuum helps to suction or pull air, pull blood into your tire, okay? Patients who like this, like that it is not a medication, so you don't have to worry about side effects. Patients who don't like it think that it can be cumbersome at the time of intimacy to kind of say, hold on, honey, let me get my stuff together. So they may not like that aspect. The other thing is that constriction band is like a tourniquet. So think about when you give blood and they place a tourniquet on your arm, right? The fingers sometimes start to feel cool to the touch or tingly. Same thing can happen to the penis. So the penis can feel more cooler to the touch. It may be harder to climax or ejaculate because it's pinching the urethra. Intracavernosal injection therapy, or some patients will say trimix. These are medicines that you inject into the side of the penis. I always get deer in headlights when I say this, but it is a very small needle and most patients tolerate it very well. These medicines get you erect within 10 to 15 minutes on their own. Foreplay helps, but they're going to work on their own. They are medicines that typically have to be refrigerated. And so if you're traveling, you got to put it in a cooler or a Yeti. These medicines, if you use too much, they can cause a prolonged erection. So when you hear those commercials saying, if you have an erection longer than 4 hours, right? This can happen with these. So at Georgia Urology, we usually do a titrating dose where we bring you into the office. We teach you how to give the injections. We kind of figure out what injection strength you need. And once you feel comfortable with it, you can keep using it. Side effects, one, if you use too much, you can cause issues. But two, every time you give yourself an injection, it's like a small injury to the penis. So if you give it at the same site over and over, you can develop scar tissue, and that causes that curvature or Peyronie's that we were talking about. So we teach you to alternate sides and kind of go up and down the shaft to prevent that. And then penile implants. So of all the treatment options, the penile implant has the highest satisfaction rate, not only for the patient, but also for his spouse or his partner, okay? This is a device that's completely inside the body. So if you were naked at the gym, no one knows you have anything in. And it does not change your ability to urinate, doesn't change your ability to ejaculate, doesn't change your sensation. Whatever those are today, they will continue to be afterwards. All that the device does is get the penis firm. And it's sometimes easier to look at it in multiple different views. So we're going to show some videos here in a second. But Boston Scientific makes the AMS 700, and this is kind of the longest lasting penile implant that we have. And it's made up of 3 different parts. So there's a reservoir, which is a balloon filled with water or saline, really, cylinders that go in the penis, and a pump in the scrotum. And the way that the device works is when you're not using it for intimacy, those cylinders in the penis, they're soft. So the penis is soft or flaccid. When you're ready to use it for an erection, you reach down to the pump in the scrotum, press it several times, and that moves fluid into the cylinders to get the penis firm. The penis stays firm as long as you want it to. 1 minute, 1 hour, 1 day, 1 month. It will stay hard until you let it down. So patients like this device because it brings back spontaneity. You know that you're going to get an erection on demand, not, honey, where's the injections? Honey, where's the vacuum pump? Did I take my Cialis on an empty stomach? If you're ready to go, it's ready for you within 30 seconds of you pumping it up. And the other thing is it's going to stay firm until you're ready to let it down. So no more wondering, am I going to last long enough to satisfy? Am I going to be satisfied, right? Am I going to lose my erection before I even make it to the game? So this will stay firm until you're ready to let it down, even after you ejaculate. So let's watch a video and I'll kind of talk us through it. So like I said, this device is made up of 3 different parts, and all of this is underneath the skin so no one can see you, okay? No one can see that anything is inside. The pump that's sitting in the scrotum between the testicles, you would reach down to the scrotum, press that several times, and it moves fluids into the cylinders, and then the cylinders get firm. Sometimes patients will ask me, how firm is firm? It's firm enough for anal penetration. When you're finished, you hit a little release button on that same pump. It moves the fluid back into the reservoir and the penis gets soft. And that's the entire process. So what can you expect about the penile implant surgery? Every provider is different. For me, my surgery, I do it as an outpatient surgery. So you come in, you have surgery, you go home that same day. Either there will be an incision kind of at the top of the penis where it connects to the body, or on the underside where it connects to the scrotum. But through one of those incisions, we usually are able to get in the entire device. When you go home, I usually tell you for 3 to 4 weeks, you want to be resting, taking it easy. You don't have to be bedbound, but you don't want to be up on your feet. I tell patients all the time, I shoot it straight with you. You're not going to like me for those 3 to 4 weeks. The incisions that we make are typically very small, and it's a lot of material, a lot of pieces to get in through a small incision. So you're going to be sore, you're going to be swollen, you're going to be black and blue. You're going to have pain medicines to help you through all of that. It's not going to be to where you can't breathe or can't walk around, but you're going to feel sore. And so you want to take at least 3 to 4 weeks for majority of my patients for that swelling and soreness to go down. And when you come in, we then teach you how to inflate and deflate it. So when you think about satisfaction rates with the penile implant, like I said, of all of our treatment options for ED, it has the highest satisfaction rate. 95% of patients who have the device said that they were happy with it. 95% of patients were satisfied with their sexual activity, right? So not only am I happy that I got it, but it's lasting and doing what it needs to do in the bedroom. And 97% said they would refer a friend to get it done. Big thing, cost and coverage. Majority of insurances cover it. We have a program where we'll partner to figure out how we can get coverage for you. But majority of insurances cover it, including Medicare. And as with any surgery, there are risks. So risk for bleeding, where you need a blood transfusion, typically less than 1%. Risk for infection ranges anywhere from 1% to 3%. It's important that we keep the device as clean as possible. And so I stress to my patients, hey, I really need you to follow my post-operative instructions. We've only got one chance to get this right the first time. I don't want to redo it. You don't want to go back through it. So make sure you're following the instructions to prevent any infections, okay? It is a mechanical device. Parts on your car, wear and tear. This typically lasts 10 to 15 years before it wears out. If you're still sexually active, you would need another surgery to put in a new device. If you're no longer sexually active, no worries. You can leave it in place. We don't have to do anything for it. So I hope, you've gotten a lot of information on ED and different treatment options. There's a link here, edcure.com/video series. That way you can see other patients who have suffered from ED and have gone through the treatment options and where they are now. And like I said, towards the end of the webinar, we'll take time for questions. So if there's any questions that's come up while I've been talking about it, please put it in the chat and we'll address it at the end. So we're going to switch gears a little bit and talk about stress incontinence. So this is laugh, cough, sneeze, pick up something heavy, golfing on the golf course, playing on the floor with your grandkid, right? And you leak urine. It's not that you got a sudden urge, oh, I got to get there, I can't make it in time. It's no, I was doing something that put some strain on my abdomen, right? Coughing or, picking up something heavy, and now I've leaked urine. And majority of the time, patients who have stress incontinence, it's related to prior surgeries, typically related to prostate cancer treatment. So whether that's a prostatectomy, or even if it's radiation for prostate cancer. If we kind of go over the anatomy just a little bit, you have your bladder on top, stores your urine, right? Prostate sits right below it, and then right beyond the prostate, kind of on the underside of the prostate, is the sphincter. And that's the muscle that you control to say, I don't want to use the bathroom right now. Now, females are very aware of this muscle because we use it all the time, right? Men, on the other hand, typically don't have to use it because your prostate, for the most part, kind of acts like a natural sphincter. So usually when your prostate's in place and you haven't had surgery or radiation to it and everything's functioning like it's supposed to, when you laugh or you cough or you sneeze, that prostate blocks any urine from coming down. When we treat that prostate, whether it be with surgeries or radiation, now the prostate doesn't always act as a natural sphincter. And so now you're dependent upon that muscle, that sphincter that's there to do all the work. And unfortunately, for some men, that sphincter just isn't strong enough. And so when you do any strenuous activities, you'll leak urine. Okay. So common causes, like I said, the most common cause is prostate cancer surgery, but pelvic radiation, urethral surgery, so surgeries on the urine channel, certain neurogenic conditions can cause issues with your sphincter as well and cause issues with stress incontinence. Okay. And similar to erectile dysfunction, this is a quality of life issue, right? You're not going to die from ED. You're not going to die from urinary incontinence, but your quality of life will take a big hit. And so if it's something that is bothersome to your quality of life, then it's something that we can address. So when we think about treatment options for stress incontinence, and we think about, what our options are. We've kind of gone through this as far as where is the prostate located, how we remove it, where that muscle that you control is located. And the treatment options really fall into behavioral things and surgeries. There is really no medications that we can use for this. So some behavioral changes will be, drinking less fluids so that you have less urine in your bladder. Going to the bathroom at routine intervals so that you're less likely to leak. So if you know, hey, I'm going on the golf course, I'm going to go and use the bathroom before I start. Or if I'm going for a quick run, I'm going to use the bathroom before I go, so that every time my foot hits the ground, I'm not leaking urine, right? Other coping methods is when you say, okay, I'm going to use a pad, or I'm going to use a liner, or I'm going to use a brief, or I'm going to use a clamp or something to prevent the leakage, right? This isn't treating it, it's just trying to cope with it. And then there's also pelvic floor therapy. So that falls underneath that behavioral and physical therapy, where you're trying to work on that muscle to get that muscle stronger so that you have more control and you can kind of clench down when you don't want to use the bathroom. But we know for patients, usually after 6 months or so of physical therapy, that's as best as that muscle is going to get. So although you may say, hey, I'm doing my Kegels every day, I'm doing my pelvic floor exercises every day, after about 6 to 12 months, wherever that muscle is, that's the best the muscle's going to get. And if it's not enough, that's when we start looking at procedures. So there's 2 different procedures for men's stress incontinence. One is the advanced sling, and the other is an artificial urinary sphincter. The sling is typically for patients who have more mild to moderate leakage. Okay, these are patients who may be using pads or liners. They're not soaking necessarily their clothes. And usually it's better for patients who haven't had radiation, just because radiation changes the dynamics of the tissue. But the way that the sling works is I liken it to a hammock. Okay, so if you look at the screen, this is kind of looking as if you're laying on your back and your feet are kind of bent and open. Okay, this hammock supports the urethra so that when you laugh or cough or sneeze, it doesn't move as much and doesn't cause the leakage. Okay, so the nice thing about the sling is if anyone's ever had hernia surgery and has a piece of mesh, you don't think about your mesh. You don't activate your mesh. It's there and it does what it's supposed to do. Similar to the sling. Once we put it in, it automatically repositions the urethra and does what it's supposed to do to help the leakage, right? So when you're laughing, coughing, sneezing, you're not leaking to the same degree. Our goal is to get you to one thin pad or one thin liner, or dry, okay? But remember, this tends to be better for patients who have mild to moderate stress incontinence and have not had radiation. The other option is the artificial urinary sphincter. So this is considered kind of the gold treatment for stress incontinence. This is another 3-piece device similar to the penile implant, but it's completely inside again, so no one can see anything, okay? This device, the 3 parts that it has, so there's a balloon that stores water in the abdomen. There's a cuff, like a blood pressure cuff, that goes around the urethra, and a pump in the scrotum. When it's in and functioning, that blood pressure cuff is squeezing on the urine channel so that as you laugh or you cough or you sneeze, nothing is leaking through. When you're ready to use the bathroom, you get the sensation, hey, I have to go. You reach down to the pump in the scrotum, you press that pump, and that cuff pops open. So now you're able to use the bathroom like you normally do. Over the course of about 90 seconds, that cuff closes back down and you go back to being dry, okay? So that's how this device works. It is, it is something that I really enjoy doing because although ED is very important, leaking urine every day when you just are trying to play with your grandkids or work in the yard can really affect your quality of life when it's something that you deal with every day, multiple times a day. And so the artificial urinary sphincter really does give patients back their quality of life with it. So let's look at a little video to explain. So like I said, 3 parts similar to the penile implant, but allowing you to control your urine when you're doing different activities. So you'll see this patient has the pump in the scrotum here, okay? Their balloon here and a cuff. at the urethra. So when he wants to use the bathroom, he squeezes that pump, that cuff relaxes so that the urine flow can come out. And over the course of 90 seconds, without you having to do anything, the water goes back to that blood pressure cuff or that urethra cuff, and it squeezes the urethra shut. So this tends to be good for patients who have more severe stress incontinence, or for patients who've had radiation because your tissues are a bit different. It's also an outpatient surgery, also small incisions, still no strenuous activities for 4 to 6 weeks. And one of the key things after this surgery is that we leave the device deactivated, meaning after surgery, you are leaking just like you are today, okay? We have to give it 6 weeks to heal, and then we activate it and teach you how to use it, okay? And this just goes to show how happy patients are after having this device in place. One of the questions that I get sometimes is, well, can I have a sphincter and also have a penile implant? Yes, I have a lot of patients who have both. There's enough room for everything, okay? But it really can change your quality of life. Similar to the penile implant, this is typically covered by insurance. Medicare definitely covers it, and we'll work with you to figure out what we can do for coverage. Also similar to the penile implant, there are risks. So risk for bleeding, where you need a blood transfusion, less than 1%. Risk for infection, 1 to 2%. Same rules apply. You know, we want to keep it clean, keep it from getting infected. Will wear out over time, just like the other one. This one usually lasts anywhere from 7 to 12 years, so maybe not as long, partially because you're using it so many times every day. You know, typically we want you using the bathroom 4 to 6 times a day, so it gets more use in a shorter period of time. Okay. So I know we have kind of covered a whirlwind of information, and I hope that it's been informative.